everyone. Good morning. We'll just give people about a minute to join, and then we'll get started. Let's see. Well, it looks like, wow, already up to 40 participants. Okay, great. I think we can kick off. So hello, everyone. Good morning, good afternoon, and good evening. My name is Catherine Hashim, and on behalf of AVAC and the WHO, I'd like to welcome you to today's webinar on PrEP and the role of HIV self-testing. Before we start, just a few housekeeping announcements. Please keep yourself on mute, but if you have a comment, please add it in the chat. And if you have questions you'd like our speakers to answer, please use the Q&A function, which you should see along the bottom of your Zoom screen. Please note this webinar is being recorded and will be circulated and posted on avac.org and prepwatch.org after the webinar. So what can you expect from today's webinar on HIV self-testing and PrEP, and why are we here? So at IAS 2023 last July, WHO issued a new recommendation to offer HIV self-testing for PrEP initiation and continuation. We know that provider-administered testing may be a barrier to PrEP uptake in some contexts, and offering HIV self-testing as an option may increase access to PrEP, will continue to simplify PrEP delivery. However, we also know that many questions remain on how to effectively roll out and scale up HIV self-testing for PrEP. So by the end of today's webinar, you will understand the latest WHO recommendations on use of HIV self-testing for PrEP initiation and continuation, including how to identify a high-quality WHO pre-qualified HIV self-testing kit. You will hear from an experienced panel of implementers and researchers on how they were able to scale up HIV self-testing, and you will get your questions on HIV self-testing and PrEP answered by the experts. And now finally, a brief overview of the agenda. So after this slide, I'll hand over to Dr. Cheryl Johnson from WHO, who will provide a comprehensive overview of WHO guidance on HIV self-testing. Then Carlotta Baptista da Silva and Michelle Rodolph from WHO will lead a panel discussion. And we've got an excellent panel of experienced implementers and researchers who will be sharing their experiences on HIV self-testing, and we'll formally introduce them at the start of the session. And then after the panel, we have about 25 minutes for question and answer and discussion. So as a reminder, please do add your questions to the Q&A feature at the bottom of the screen. Add them as they come up, and then we will address them to our panel and speakers during the session, the Q&A session. Today, we'll use the questions and comments that come up to help us identify where people are struggling the most with HIV self-testing for PrEP, so we can address these issues with a small group of experts at our next Biopic think tank. So please do be as open as possible during the discussion and Q&A so we know where to direct our efforts to help you. And then at the very end, Dr. Johnson will wrap us up. So now I'd like to hand over to Dr. Cheryl Johnson to tell us more about WHO's perspective on HIV self-testing. Thank you.
Excellent. Just sharing my screen. So happy to be with you all today. Great. Just checking in, Kat, is everyone seeing my screen?
Yep, we could see your screen.
Yes.
Yep.
Help if I started at the beginning, the slides. So fantastic. Excellent. So I'm so delighted to be with everyone today, and thank you for the opportunity to share WHO's guidance and some of the latest developments on how we can really optimize the use of self-testing for PrEP. In this presentation, I'm going to first outline kind of self-testing 101, just to get everybody on the same page when we talk about self-testing. What do we mean? Why we think it might be helpful to solving some of the public health problems we're facing and how to increase access to PrEP. And also then give a little bit of a update on the WHO guidance and country experiences and some of the future directions and the way forward that we're starting to see before we go into the deeper conversations with countries. So as a kind of introduction, when we talk about self-testing, it really sits within a broader structure of self-care. And this is where, we're focusing on the range of different approaches, but for us, we really focus on self-testing at WHO, particularly for HIV. And there's a difference when we think about self-testing versus, say, even self-sampling. So in today's webinar, we're focusing particularly on self-testing, which is where individuals collect their specimen, perform the test, and then interpret the results either alone, in private, with someone they trust, really at their own convenience, how and where they want. Now, self-sampling is also very important, but we're not covering it today in this webinar. And in general, self-testing and self-care, they're critical to the health system. And we see actually how it increases efficiency, is important to really increase engagement and autonomy, creating access and equity, improving quality of care, can help reduce health system costs as well as costs to individuals. And it can also really help our efforts to expand UHC efforts. And when we think about self-testing as well, there's really a kind of a framework that's been developed to think about what are the direct impacts? Why are we even thinking about self-testing? Well, first and foremost, it can really help us reach those underserved priority groups. That might be key populations, adolescents, men, people that we're not generally reaching through traditional services. But even people who were reaching through traditional services, they could benefit from being triaged out of the health system, being able to save time, precious resources. And we see a direct effect where self-testing can help link people to prevention. It can help with disclosure and sharing of status, which is important for HIV prevention as well as that linkage to treatment. And in today's webinar, we're really going to talk about the role self-testing plays with access to PrEP. So over time, WHO has developed a range of recommendations on self-testing. So starting in 2016 with the first recommendation and then followed by a pre-qualified product, we really pushed forward with self-testing quite early. But since then, there's been a lot happening across STIs, with syphilis self-testing now recommended, hepatitis C self-testing. We also have seen a lot of things happening during COVID where self-testing became quite universal in many settings. And then in 2023, as Kat mentioned, WHO recommended self-testing for PrEP initiation, reinitiation, and continuation. And we also see that it's even being explored in some of the long-acting spaces, but we'll go into some of that a future direction later. So when WHO talks about self-testing for PrEP, really the strategy that we're talking about is where an individual will perform a self-test. If it's reactive, they need to be linked to further testing to provide a positive diagnosis to then be linked to treatment. But if it's negative or non-reactive, this is considered negative. And we are going to link this person to PrEP if desired. So we don't need an additional test to confirm that negative self-test to initiate or continue PrEP. Globally, we've seen incredible adoption of self-testing, particularly in Africa, as you can see in this map. And based on last year's reporting, we know over 100 countries now have policies in place and are implementing self-testing widely. And this just gives you a sense of the timeline that it's been quite a long road for self-testing. A lot of developments have happened and are still kind of on the way. So I think this is a very active and compelling space that is really relevant to think about and reflect on as we think about applications to PrEP. So we've got a lot of evidence on self-testing, and I wanted just to highlight a couple of the core systematic reviews that have summarized key findings, as well as some of the recent modeling too that we'll talk about and hear from some of our panelists later on self-testing for PrEP. But just to summarize what we've learned about self-testing over the past 10 years is really that one, self-testing consistently has increased frequency and uptake of testing, is very good at detecting people with HIV and kind of having good positivity or yield. We haven't seen any issues of social harm, including with large studies that have documented over 1 million self-tests and looked for any serious adverse events. We know that self-testing is safe and accurate and very reliable. We have 6 pre-qualified self-tests now, all very usable and accurate. We've seen different facility-based or social network distribution models to be very effective, and even web-based or virtual models working quite well. We see groups like key populations really prioritizing and benefiting from self-testing, seeing it more than double the uptake of testing. And we've also seen that we have good linkage as well. So a recent systematic review found that self-testing linkage post self-testing really was generally high, particularly with some type of assisted or a social network-based self-test. And we do see now with PrEP that self-testing has had comparable effects on effective PrEP use, and that it's been really acceptable, feasible, and preferred compared to standard testing. And some of the modeling has really showed us that there's a really low risk of drug resistance, that we have similar health effects and costs compared to standard testing. So a lot of benefits. So we've learned a lot over the years, and it's a great time to really be thinking about how we can scale up self-testing for PrEP. Now, before we go into some of those details, in case many people haven't done a self-test yet, we just wanted to show quickly what a self-test might look like. I'm just going to pull up this short Q&A video. So bear with me. Here. Assured and regulated. There are oral and blood tests for self-testing. The test results are available in 20 minutes or less. And these options are critical for users who have different values and preferences. So for some, an oral test is easy, it's painless, they don't have to prick their finger, that's just a swab of the mouth. And there are also blood tests, which are finger prick tests that are simple and quick. For others, a blood test, they may trust blood more, they may prefer to have that result. So there's different options for different people based on what they desire or need. The costs vary substantially. There are a number of efforts underway to reduce the costs, and current projects are offering them for free or subsidizing them to create access. Great. So a little embarrassing for people to see me 10 years ago, but just to say that gave you a little bit of a sense of the oral tests as well as the blood tests and how easy those are to perform for individuals. These are the tests I was alluding to that are pre-qualified, as well as some that have SRA approval. And, what we really see is that we have affordable products now, even a test that's available for just under $1. We have private sector accessibility. We have strategic funds like in Latin America that help promote access. And sometimes we get the question, well, do people prefer oral over blood? Which one is better? And what we've really seen is that, as we've alluded to in the previous video, both options can be really beneficial. And there's actually no significant difference in uptake between oral and blood in systematic reviews of available evidence. So now on to PrEP. So when we think about PrEP and where we've come, the guidance has evolved substantially over the years from 2012 till now, and there's lots of materials supporting the differentiated service delivery of PrEP, new guidance on PEP and expanded self-care as well that is really coming out. And I think in this differentiated service delivery document from 2023, we really have seen a lot of advances on the potential for self-testing, especially due to new models for PrEP delivery and simplifying PrEP to be more accessible and easier for different types of users to support their journey and their varying levels of risk that change over a course of a lifetime. But one of the key problems, despite the guidelines that we have, is that we just aren't getting enough people access to PrEP. And effective use continues to be a challenge for many, especially during periods of risk. And without increasing PrEP uptake, we're not going to be able to achieve our WHO targets to have fewer infections by 2030. Additionally, sometimes when we've historically thought about someone's PrEP journey, we've been very kind of systematic, thinking someone's going to start PrEP, they're going to come for their quarterly refills and visits, and they're going to stay on PrEP forever, and they're going to stay negative forever. But that's not reality, and people's journeys and their lives are a lot more complicated. Sometimes they're going to be positive and need to link to care. Sometimes they might be missing doses or splitting pills. There might be challenges accessing services when and when they want to. They might be starting or stopping PrEP, taking long breaks. Sometimes they might not be able to make it to the clinic. Their period of risk changes or stops for a season. And then it kind of may evolve again over time. So I think we want to factor that into all of our thinking, and that's where self-testing comes in as a much more flexible option to accommodate people's complex lives. And as I was mentioning, the WHO released that simplified service delivery guidance for PrEP, highlighting a number of community-based options, whether it's teleprep or pharmacy PrEP, home-based delivery, even mobile PrEP services. And all of these can be facilitated through self-testing. Now, in our WHO guidance, we outline a couple of different ways that self-testing can be used. So first and foremost, it can be used for demand generation to link people to PrEP, and that's an older recommendation, but can still be quite important. We really focused on how self-testing can be used for initiation. So it can be used to get started on PrEP, but then it can also be used for continuation. So really as prescribed, as needed, or as desired in between visits. And so this is something we really see as various options to support different people and the different service delivery models that might be out there. Now, this guidance was based on a systematic review that really highlighted that the benefits of self-testing really outweighed the risks. The evidence was really based on trials where we saw a lot of good adherence, good retention and support on refills, good uptake, no adverse events or social harms, and high feasibility, acceptability, and good resource use as well. And just one of the studies, which we've got a speaker today who will reflect on their experience, really highlighted that in their 6-monthly PrEP dispensing program with self-testing, that simplified PrEP delivery did not compromise clinical outcomes, was highly acceptable and cost-saving. Now, when we think about the risks and benefits, there's a lot of things we want to really reflect on for the real world. So as I was mentioning, simplifying PrEP and adapting services, we see self-testing as a way to be flexible to clients, creating that engagement, that ownership, enabling things like teleprep and virtual services, increasing access to PrEP, in general, making just more options for more people to be served. When it comes to PrEP services, it can really help simplify and reduce the cost of service delivery, enable more task sharing, reduce health worker time and the need for facility visits. And that client opportunity cost is sometimes not even calculated from the health system perspective, but is really important when we think about what clients bear in terms of the travel and complexity of making it to the clinic very often. Now, there's always been questions, will self-testing miss a lot of people? What if we miss an acute infection? What if we miss somebody and they develop drug resistance? But really what we've seen from the Cox 2024 paper was that self-testing supported PrEP would really not result in many missed infections, and that there was a very low risk of affecting drug resistance at a population level. And there's really no substantial difference what we've seen when we compare self-testing to standard testing available across low and middle income countries. So what does this really mean? Are we going to start using self-testing and then miss out on other important clinical services? And the answer is actually not necessarily. One, self-testing can be used at a clinic, and we're seeing some countries do that as another option. But we're also seeing advances in self-testing like dual HIV syphilis self-tests, emerging self-collection and self-testing approaches that are covering also other disease areas. So just because we add self-testing in doesn't mean we're going to miss out on STI screening, because there might be other tools that are available with more self-care and self-management perspectives. So what are we seeing in terms of country uptake on WHO guidance on self-testing? So it's almost a year now since the recommendation come out, and we're seeing some early adoption happening, and we've done some mapping. I really want to thank my colleagues, Carlotta and Matteo, for really supporting some of the work that we're doing on mapping. But what we've started to see is that many countries have, historically been using self-testing for demand creation. But we're starting to see countries start to use self-testing for PrEP initiation, for reinitiation, but also for continuation. And we're going to hear from some of those countries today. So first, from Eswatini in the FHI 360 and EPIC program, we see that they're using self-testing for PrEP in a variety of ways. So starting just recently in March 2024, they updated their guidelines to include self-testing, and they are using it for initiation, including the oral PrEP, as well as the dapivirine vaginal ring. And they are using kind of self-care and self-testing to promote the refill till month 4. And during this refill, PrEP is given for 6 months, and then clients are educated on the use of self-testing without the need to come to a facility. So both oral and the ring, those versions of PrEP are provided with a self-test so that users can take them home, use it as an exit test in case of a decision to discontinue PrEP as well, if their risk change. And then with ART initiation, we also are continuing the historical program that self-testing can be used and distributed as part of index testing, more broadly, even outside of the PrEP program too. So a really great experience that we're going to hear more about from Eswatini and the panel. Now in Vietnam during COVID-19, that really stimulated their shift to using self-testing for continuation. So here they issued an order that in the kind of situation of a disaster or pandemic, they started to get the approval for self-testing for PrEP. And one of the pathways that they really saw was that when they started to use self-testing for PrEP, it really helped maintain that essential PrEP service, keeping people on PrEP who really needed it, who remained at risk. So this was a really important kind of COVID adaptation that is really a great lesson to learn from even beyond the pandemic period. We're going to hear a little bit more from Vietnam in the panel as well about how post-COVID they're using self-testing to support linked to PrEP and tele-PrEP as well. Now, HIV self-screening, or as it's called in South Africa, the program in South Africa has really been growing, and both self-testing as well as PrEP are quite large programs. So now they're procuring, I think, for the next cycle, almost 4 million self-screening kits. Their programs have historically targeted men, adolescent girls, and young women in key populations. And they've been very high yield in terms of reaching people with HIV who don't know their status. Now, the current guidance focuses on reaching those who are over 12, and those who are between 12 and 17 require assistance. But in their new guidance that's just been coming out, they have self-screening for PrEP that supports demand creation, continuation, and reinitiation, but really does require that direct assistance from a provider. And there's some exciting work happening now with tele-PrEP being implemented with self-screening as a pilot. And here are two kind of flow charts about the client pathways where we might have self-screening happening with oral PrEP at a clinic where the nurse is there and then the self-screening is taking place. But it can also happen at a decentralized collection point as well. So now I just want to give some time actually to one of the users of self-testing for PrEP in the South African program. So I'm just going to play a short clip from one of our user beneficiary experiences and thank the HIVST team for providing this video.
Self-testing was fine. There was no hassles, and it's more comfortable than doing it at the hospital or clinics. And yes, I will continue using the self-test using the PrEP use.
Right. So I think reflecting on those user experiences, that self-testing might have been more preferable, particularly as it prevented the need for another clinic visit or having to really go through the trouble of travel or kind of engaging with a health worker that may not be optimal for all populations, really shows that there might be a lot of benefits in increasing access to PrEP through self-testing. So when I think about the way forward for self-testing, particularly in the context of PrEP, it's really important to think about where we're headed and how we're going to achieve our prevention goals. So we've really seen that by simplifying PrEP delivery, we can really increase access. And testing is such an important part of simplifying PrEP delivery. In the past, I think the testing program sometimes wasn't really thought about as a barrier, but we heard it through community consultations with AVAC and others that testing was too complicated. Coming to the facility too often was a challenge and really preventing a lot of people from engaging with PrEP effectively. So I really want to underscore that based on the evidence and the consultations with community, we can't continue with business as usual and expect that PrEP scale-up will happen on its own. You know, self-testing is really an evidence-based approach that can be utilized to really make an impact on achieving prevention goals and averting new infections, which is critical. And while there may be concerns and questions, we have to apply the lessons learned from some of these early adopter countries, which is why it's so important to have webinars and discussions like this. So really excited to hear from the country experts and colleagues that will be speaking with us shortly. In terms of the way forward, when we think about self-testing for other types of prevention, there's a lot of uses for PEP. So I don't want to leave that out. While that's not the focus of our webinar today, PEP is a critical component and really an area that we could be thinking about for future use. Also, there's something I mentioned that within the long-acting PrEP space, we're seeing a lot of programs that are doing early implementation research, using self-test in between visits or finding ways to think about how it could add value. And so there's going to be a lot more research underway in this space that will inform WHO guidance in the future. So stay tuned for more updates on long-acting PrEP. And then lastly, I think one of the big challenges when we started thinking about simplification of PrEP and testing was this concern that if we move out of the facility, are we going to move away from this great public health package, miss out on other important clinical services? And I just want to say that self-testing is no longer just HIV. There's actually a lot of tools and technologies for self-testing, self-care, self-management that we can draw upon and bring into these different types of PrEP models. So I think we want to think comprehensively that we can be using STI self-tests, we can be using multiplex self-tests, We can be optimizing teleprep and virtual systems that we learned a lot about during the COVID-19 pandemic period, and really say, hey, let's not go back to the old systems and really apply these because they work for a lot of people. People have complex lives. We've definitely learned that through this work. And it's important that we provide services that are really going to be flexible and put clients at the center. So I want to thank everybody just who helped prepare this presentation as well as organize this webinar from the WHO and AVAC teams. I really want to share a big thanks to the countries and implementers who shared their experiences on self-testing and PrEP with us, especially our speakers from South Africa, Vietnam, and Eswatini today. And I also want to thank Manisha Sharma and Katrina Orkblatt. They're joining the webinar today. Their teams at University of Washington and Fred Hutch have been really helpful to WHO in the generation of evidence, including some of their implementation studies, systematic reviews, and modeling work. And then lastly, I want to thank the beneficiaries who shared their experiences, and the HIVST team, Mohammed Majam and Angela Tembo, provided some videos and input from users about their experience with self-testing as part of PrEP services. We have a number of resources on the WHO website if you want to learn more about testing, and we're always available as a team, so feel free to reach out to us via email about how we can support. So thank you so much for your time, and back to you, Kat, and to the chairs who are going to be moderating the panel, Carlotta and Michelle. So over to you.
So thank you so much, Cheryl, for setting the scene with such a great presentation. Good morning, good afternoon, and good evening for some of you. It's a pleasure to be here with you to moderate this interesting panel with my colleague Michelle from WHO. This is a panel that is actually dedicated to sharing practical case-based examples that highlight many of the challenges shared by you, with the aim that to hopefully clarify many of those concerns and therefore enhance the uptake of HIV self-testing for PrEP delivery. For this, we are privileged to have a diverse group of panelists, including representatives from the Ministry of Health, implementing partners, researchers from all over the globe, including Eswatini, South Africa, Vietnam, and the US. We are positive that their insights and experience will enrich our discussion. We'll open the floor for questions in the end of the session. However, if you do have any questions for our speakers, please type them into the Q&A, specifying which speakers your question is directed to, and we'll address them in the end. We look forward for your active participation and engaging in a productive session today. So thank you for joining us today. I will now hand over to my colleague, Michelle Rudolph, who will introduce our first panelists and will launch the initial round of questions. Thank you.
So I think it's good morning, good afternoon to most of you. I am noticing that one of our first speaker is not online yet. Dr. Nyan, or is Dr. Nguyen online? I'm looking for Dr. Van. Okay, so we're going to move to the next speaker, so change the order of things. Vusi Dlamini, are you online?
Hi, Michelle. Yes, I am online. Thank you.
Okay, and I'm certain I got your family name incorrect, so my apologies. I've been trying to pronounce your family name for many years. So I just wanted to ask, so if you could, I'm going to just ask, so Dr. Vusi Dlamini is a clinical technical officer from FHI 360 in Eswatini. So I just wanted to kind of start this with just a little introduction that we all know that a significant challenge in many countries is a concern regarding the use of HIV self-testing for PrEP initiation. While numerous countries use HIV self-testing to create demand or enhance PrEP uptake, very few are actually using self-testing for PrEP initiation. Eswatini is one of the pioneering countries implementing self-testing for this purpose. So thank you, Dr. Dlamini, for being available to share your insights with us. So just to get the conversation going, we'd appreciate if you could describe the process, including the rationale behind the main concerns and how these were addressed, as well as the process from implementation to policy change. Over to you, Dr. Vusi.
All right. Thank you, Michelle, and good day and greetings, colleagues. I assure you that you pronounced my surname very well. So, and thank you for the question. So, I think I work for EPIC Eswatini, which primarily focuses on key and priority populations. I also sit within the PrEP core team in Eswatini that is responsible for most of the decision making around PrEP implementation. So possibly to start off with, I will start off by saying that, we have been utilizing for PrEP in the country for some time, and historically, we have been using it for PrEP demand generation at community level. We have also been, utilizing it at facility level for screening. In the past, we were utilizing paper-based screening, but we then realized they were actually screening out some of the clients that are eligible for testing. So we then moved to utilizing HIV self-test as a screening tool. So I can also mention that, we have been screening with HIV self-test kit and then testing clients utilizing Determine as a standard of care prior to PrEP initiation for those clients who would, accept PrEP. And this would take pretty much a lot of time, which is around, almost 50 minutes in terms of this, because it's 20 minutes for the Determine, and it's also around 20 minutes for the PrEP, for the HIV self-test. And we're also, utilizing both unassisted and assisted modalities in our country. And I can also mention that we are utilizing OraQuick, which is, oral-based HIV self-test equipment. At the moment, we are still exploring options of blood-based HIV self-test. So then now in 2024, around March, after following some considerations and recommendation around the usage of HIV self-test kit for PrEP service provision, our Minister of Health, updated the PrEP implementation guidelines, which outline the use of HIV self-test for PrEP initiation and continuation. That is inclusive of oral PrEP and also the vaginal ring that is still being piloted in Eswatini. So in terms of the processes around HIV self-test utilization for our clients, so we have quite a number of more modalities. So firstly, when our clients are coming for service provision, I think ideally they will be waiting in the waiting space before they can interact with the clinicians. So they are provided with health talks. They are also given HIV self-test kits for them to screen themselves prior to going to see the healthcare worker. In community level, we also providing HIV self-test kit, and they are being utilized by our community CAIDAS, community mobile outreach workers, who also provide assistance in terms of screening for our clients prior to going to the clinician for service provision. A lot of modalities. In some facilities, we have booths that we are utilizing for our clients just to get that private space for them to self-screen. In other facilities, they are also provided with assisted, self-test, self-testing, and in others, they're also using, those gazebos just to provide the privacy. And really, we are aiming, to promote self-care to our clients. And at the moment, we initiate our clients based on the HIV self-test result. In the past, we will then do a blood-based RTT, and in our context, it was Determined. So now we just initiate using the HIV self-test result. And additionally, as our clients continue with their PrEP, they then come for refills And when they are adherent and they are coming on time, on their second refill visit, they are then given multi-month dispense or prescription of PrEP with an HIV self-test kit that they will then use at 3 months interval without coming to the facility. Because in the past, they will be coming every 3 months to come and you collect their medication, get tested, you know, time and again. So this applies for both the oral PrEP and the vaginal ring. And additionally, all our clients are actually initiated on PrEP and also given HIV self-test kit. And they're educated, you know, to utilize the HIV self-test kit. In cases they feel that their risk have actually changed, they are opting to discontinue PrEP. We encourage them to self-screen at home. And in case of those who are on event-driven PrEP, we also give them HIV self-test kit so that they can be screening themselves at the comfort of their home. Because in the past, you'd find that they have enough medication and they will not be coming to the facilities for refills. So really this self-test is very convenient for our clients that are also on event-driven PrEP, and they are very appreciative of that. So really in our Ministry of Health, just in terms of, you know, our policy change, we have our defined, you know, strategies to reduce our HIV new infections on yearly basis through our coordination body, our Eswatini National AIDS Program. And part of our goals, you know, we want to improve PrEP uptake and also increase continuity for our clients that are eligible to ensure chances of them getting infected with HIV are actually slim. And, you know, part of what we have planned, definitely want to demedicalize PrEP service provision. We want to simplify, you know, options around PrEP service delivery. We also want to differentiate, you know, our service provision, not to be stereotyped around, you know, clients coming to the facilities frequently for refills, yet some of this can actually be done by their client if they have been trained enough. And part of what we are doing as a country, at the center of our service provision, we have our clients. Time and again, we engage them just to have a feel of what they think in terms of our service provision. So I think the other part of the question, you also asked me around, you know, the rationale for the utilization of HIV self-test kit within our facilities. So the first one, our health facilities are strained, and, you know, they are overburdened by the influx of clients time and again. So really want to reduce, you know, the need for some of our clients to come to the facilities frequently. And, you know, there are always those long queues within our facilities. So really utilizing this HIV self-test kit, we can now actually disclose at an infancy stage that it is really working in terms of, you know, reducing clients that are coming to the facility. And it also, you know, works on our HR, because in the past you'd have an HTS counselor that will test the client. Thereafter, the client will go to the nurse or the doctor for service provision. So now in some other facilities, the self-test kit is just provided to the client. There is no need of some of the HR. So really we are saving in terms of our service provision. So the other thing, we also conducted some PrEP assessment surveys, and time and again we receive feedback from our clients in terms of our service provision. And, you know, they are saying they are spending a lot of time in queues. They have to visit our facilities more frequently, and they were really advocating, you know, for our ministry to review that, for them to continue taking PrEP, and also, you know, ensure they adhere and come back for refills. The other interesting thing as Eswatini, we are actually, doing some case reviews amongst our PrEP seroconverters. And one of the interesting findings that we got that is actually common, one of our clients said, I had discontinued PrEP, while I was still at risk of acquiring HIV. And as we probed further, I think a number of our clients said I actually came to the health facility and I waited in the queue and I had to go because the clinicians were taking long to give me the service. Then they got HIV. So really, this HIV self-test has actually eased in a lot of things. Yeah, I think I'll stop there, Michelle, and hear from you.
No, I really appreciate all of your insight and just describing just how much that the self-test, self-screening in Eswatini can make access to PrEP and access to prevention services in general. It facilitates them and is very user-centered. I was just jumping in because we have 4 more panelists, and while I would love to continue hearing from you, we do need to make time for them. So I'm going to hand over to my co-chair, Carlotta, who I believe will be calling on Hasina and Alaris from the NDOH. Over to you, Carlotta.
Thanks, Michelle. So another challenge we face in many contexts is the lack of trust between clients and providers with the use of HIV self-test. South Africa has also a strong experience on the use of HIV self-testing for PrEP, and to share their insights, we have Dr. Alaris Marsh, who is the Deputy Director of HIV Testing Services at South Africa Ministry of Health, and Dr. Hasina Subebar, Senior Technical Advisor at the South Africa Ministry of Health. So Dr. Hasina and Dr. Alaris, are you there? Could you turn on your cameras?
Good morning, colleagues.
Good morning. So, Dr. Hasina and Dr. Alaris, could you kindly provide us your insights on the risks you were afraid of when starting to use HIV self-testing for PrEP, and what was the reality, and also some of the strategies to foster trust between clients and providers on the use of HIV self-test? Thank you. Over to you.
Good morning, everyone. So just a disclaimer, HIV self-test is known as HIV self-screening in South Africa. So when I refer to HIVST, it's because that is what, the program is known as in our country. So with the risk in South Africa, one of the challenges that we thought we would face was social harm, especially amongst users who were not provided with adequate or sufficient counseling, including first-time testers and young people below the age of 18. We also thought of, around IPV amongst partners, because we know intimate partner violence is a key issue in our country, and we thought when people are using HIV self-screening, it would increase IPV. Forcing and coercion, especially in children and minors who are not of consenting age and who are unable to sign consent, including other consequences following the results post-testing. The use and interpretation of the test results in areas and amongst users with a low literacy. And I think the financial implications as well, the value for money, because if you look at the cost of an HIV self-test compared to the cost of our traditional test, there's a vast difference. But I think in South Africa, we can say that this modality, as much as we thought it was going to be a risk, all the risks that I've mentioned have never been reported, including the financial implication. The HIV self-screening has really reached our adverse population, our men, our key populations, and people with poor health-seeking behavior. So I think those were some of the risks that we thought we would have in the country, but we've never ever, I think like Dr. Kat had said previously, with social harm, there's never been any reports in the country. So those were just some of the risks that we thought we would see, but I think I'll hand over to Hasina to continue on behalf of South Africa. Thank you.
Thank you, and good morning to everybody, and good afternoon to those of you in a different time zone. Just to say that in South Africa, we haven't included self-screening as part of the HIV PrEP guidelines. However, we are in the process of piloting it, and we're looking at piloting it in certain areas. And I think our main concern is about using HIV self-screening where we initiate a client using just the screening as a screening test. And one of the issues and why we see that as a big issue is that screening of clients that are seroconverting may or may not exhibit signs of an acute infection when they arrive to be initiated on PrEP. There's also a lot of confusion between PrEP and PEP amongst our clients. So even if they want come for PEP, they ask for PrEP. So, you know, these are areas that we need to make sure that we're absolutely clear on. So, and what we also found over the years, as we've been initiating people on oral PrEP, we found that our clinicians are also missing signs of acute infection. And in month 1, we are identifying people that have already, we're seroconverting during this period of time, have already seroconverted. And so they have to be transitioned to oral ART. I think that, you know, for that reason, we're not looking at initiating people on using the HIVST initially. However, what we are going to be looking at is clients' ability to conduct, looking at continuing clients on oral PrEP and using HIVST. So we want to identify clients that are already stable on oral PrEP. So after their month 1 visit and they come in for their month 4 visit, hopefully by then they would be adherent to their oral PrEP. The chances of them seroconverting during this period will also be limited. What we are looking at is to say, how do we prepare the client? You know, the ability to conduct an HIV screening test needs to be, you know, we need to make sure that the clients know how to conduct a test, how to interpret the test, and so that requires preparation. So in this phase, we're looking at possibly trying to make sure that everybody who is going to be using a self-screening test for continuation will be properly educated about the use of a test, provide them with materials, both visual as well as literature that they could use when they're at home. And when they come into the clinic, provide them an opportunity to conduct the test in the clinic if they would require that, and then be routed to a healthcare provider that will continue the prescription and the rest of the assessment. We're also looking at our clients that will possibly be decentralized, and I'm going to hand over to my colleague Oropaleng, who will talk about the decentralized clients and how we plan to handle those individuals. Oropaleng, over to you.
Thank you, Hasina, and greetings to everyone. I hope that you can hear me. Yes, so just to continue on what Hasina has said. So one of the concerns that we had is that how do we then conduct HIVST for clients receiving their oral PrEP refills at different decentralized collection points? So what we say is that because in South Africa we've got different models of decentralized medicine refill and in different provinces and districts. So now, however, oral PrEP refills are not included as yet, you know, into the general decentralized medicines collection system at this stage. But then we said that then the use of HIVST for the 3-monthly HIV test for the oral PrEP clients will have to be adapted, you know, for different contexts, because we've got different contexts of DMOG and so on. Another point, concerns that we had in South Africa is the use of HIVST by persons below the age of 18 years, you know, and because those are the people who would require a thorough assisted or assistance in delivery of HIV/SS. So we are saying this will be possible. However, it should be conducted in a facility context with the assistance of a healthcare worker. And then how this will be done is that the person below the 18 years will have to present themselves at the counselor station or the youth zones. We do have the youth zones in our country, in our facilities, where these services are available. Because all persons below the age of 18 require assisted HIV as per national testing guidelines. I think you may have alluded to that when you gave us a brief overview in terms of one of the guidelines that you are having in South Africa that talks to people who are less than 18 years of age. And then one last point that we had is that the cost of HIV/SS testing kits in South Africa is substantially higher than the traditional rapid HIV diagnostic test kit. So from a cost-effectiveness perspective, the use of HIV/SS does not increase the cost of oral PrEP delivery. But then negotiating for a price reduction of HIV/SS test kit to a level that is similar to the traditional rapid testing diagnostic will no doubt, make HIV/SS a more attractive option. So at this stage, the use of HIV/SS for oral PrEP continuation will assist with reducing the client's load for the counselors and clinicians. That is as part of the mitigating factors. So I will stop from there and hand over to you, Carol. Thanks.
Thank you. Thank you so much. Thank you so much for sharing your concerns. I guess that many of the concerns highlighted here, such as the social harms on first-time testers, young people, the intimate partner violence, the use of interpretation and financial implications is something that many contexts have those questions. We have a lot of evidence on the social harms that Cheryl shared. We are happy to share again the presentation on that. We do also, we'll have a panel on the financial costs, on the financial implications that will bring a lot of clarity also on the cost component. And we will have our next panelist from Vietnam that will also talk about concerns and how they overcome similar concerns. So I will now hand over, for the sake of time, to Michelle to follow up with Vietnam. And thank you so much.
Thanks so much, Carlotta, and thanks again to the panel from South Africa. Very inspiring and interesting to hear. I'm going to call on Dr. Nguyen Thi Van, and I hope I got the right order of your names. Unfortunately, Dr. Van is on the line right now. And unfortunately, Dr. Nguyen, who comes from the Vietnam Ministry of Health, is unable to join as she has an emergency to attend to. But Dr. Van, who is with the WHO country office in Vietnam and oversees HIV, viral hepatitis, and STIs, is available to speak. Dr. Nguyen, can we pull up Dr. Van? So if you're looking for her name, I think it's going to start with an N in the chat. Van Nguyen, V-A-N. Dr. Van, can you turn on your video?
Yes.
I know Dr. Van is online. I'm just waiting to hear her voice.
Thank you, Michelle. Good afternoon, everyone. Can you hear me well?
I can hear you perfectly and see you even better. Excellent.
Thank you so
for
much.
joining us, Dr. Van. So I just wanted to jump in and ask a question really specifically about the challenges of HIV self-testing uptake for PrEP at country and program level. We know that Vietnam was one of the pioneers in offering HIV self-testing for PrEP uptake during COVID and has continued offering HIV self-testing in the context of PrEP. So we wanted to ask you about the concerns, the risks, and how this was overcome in Vietnam, either during COVID or now or as a continuation, but I leave it to you. And then just an idea, just so that you know, Dr. Van, we try to keep your response to around 5 to 7 minutes because we want to have time for questions at the end. So basically, you just give a brief overview on the situation in Vietnam and providing self-testing and PrEP. Over to you. Thank you so much.
Sure. Thank you, Michelle. Good afternoon, everyone. Yes, as Michelle said, Vietnam actually implementing HIV self-test quite early, and now we scale up HIV self-test in almost every province in Vietnam. And HIV self-test actually provided through different distribution models, including virtual platform, like we design a website so everyone can sign on an account and request for a web for an HIV self-test, and then the test can be delivered to the door. And other than that, community-based distribution, health facility distribution also implemented. So in short, HIV self-test is really available in Vietnam. So from HIV self-test and PrEP, during COVID, because of travel difficulties, so MOH have one policy allow using HIV self-tests for PrEP initiation, PrEP monitoring, to ensure that uptake of PrEP and also continuation of PrEP is ensured. But after COVID, of course, the policy is no longer effective. So the National Working Group in Vietnam actually meet in discuss because we are updating national guidelines, and we were discussing how we can adapt WHO recommendation on HIV self-test for PrEP initiation and monitoring. So we hear a different voice. Of course, many people actually really exciting, including me, that very exciting that we now have a WHO recommendation. We can use self-test for PrEP, initiation and monitoring. But at the same time, other people, especially like a policymaker, they a little bit concerned that, as some other speaker already mentioned, that how do we know that the HIV self-test is correct? How do we know that the person actually the same person they require for PrEP? And more importantly, that the current policy doesn't allow, self-tests to use the result for the prescription. I understand in some country you already decriminalized PrEP, but in Vietnam, PrEP still drug. And if we need to prescribe drugs, we had to have, policy to allow you to use a self-test result for the prescription. This discussion is still ongoing. But in fact, I think people also, because HIV self-test is so popular, so easy to get, and our PrEP users still keeping using, self-test to check on their HIV status. But of course, if in the time that they need to go to the clinic to check their HIV status, they need to do another blood-based test at health facility. One more point that they made is that for PrEP initiation, they need to do other tests. It's not only HIV self-test. So they need to go to clinic anyway. So some of us are thinking that maybe, HIV self-test for PrEP monitoring is, can facilitate the PrEP users. They don't need to go to clinic too often, but the PrEP initiation maybe, for particular people is really in the remote mountainous area. Otherwise, if they are able to come to the clinic, the first time to be able to present in clinic could be better. So for this, point in terms of challenges for using HIV self-test for PrEP, We are thinking with MOH. Unfortunately, Dr. Nhan was not here today, but she also takes me some point that we will do a pilot first for the PrEP, for the HIV cell test, for the PrEP users, to ensure that the quality of the result of the can be confident in terms of we don't have too many false positive for the cell test. Even during the implementation of HIV cell test, we see very, very low number of the people with phone reactive, very, very low, I would say. But from policymaker point of view, they think that we better do and conduct pilots, and WHO go into support MOH to conduct that kind of pilots. And then once we have the result from the pilot, we would work with MOH, or MOH can develop a policy. In Vietnam, we say circular to allow using HIV cell test result for PrEP. Depend on the conclusion, but could be initiation or monitoring or both, initiation and monitoring PrEP. So I think I also learned from other countries in the webinar today how you do it at our country, but in Vietnam we also have plans. I'm really think that HIV cell test should be a part of PrEP. Not linking from cell test to PrEP, we already did, and we received very success results. About 20% of HIV cell tests user are linked to PrEP, but to make it more advanced, like really using HIV cell test result for PrEP initiation and monitoring is something that we would like to do it in the near future. Thank you.
Thanks so much, Dr. Van. Really appreciate hearing your insight over offering self-testing in the context of PrEP in Vietnam. Really interesting. I'm going to hand over to Carlotta, who I believe who will take us through our next panelist. Over to Carlotta.
Thank you, Michelle, and thank you, Vietnam. So bringing on this very key question that was raised also by South Africa, the consideration of cost and cost effectiveness remains key in the decision-making progress regarding the expansion of HIV self-testing in PrEP delivery. We all know this. So to share their insights obtained from a modeling study on the impact of HIV self-testing for PrEP, scale-up and drug resistance and HIV outcomes in Western Kenya, we are very grateful to have Dr. Monisha Sharma. Dr. Monisha Sharma is from the University of Washington, assistant professor in epidemiology. Hello, Dr. Monisha, good morning. So my question to you, could you please share insights from your modeling study regarding the cost effectiveness analysis, specifically focusing on the differences in costs between various strategies? Thank you. Handing over.
Thanks for having me. And sorry, I sound sicker than I am. I have a cold from children. So basically, our modeling analysis was done because we wanted to understand whether HIV self-testing could be used for both PrEP initiation and continuation. So HIV self-testing, as you know, may have lower field sensitivity than provider testing, either because of user variability in user performance and also the test itself. This is particularly a concern during early HIV infection, where the ability to detect HIV is lower and the risk of resistance development in early infection it is particularly higher compared to chronic infection. So we used an agent-based model, EMOD-HIV, to assess the health impacts and the costs and the PrEP-associated resistance development associated with PrEP scale-up using 4 strategies. So blood and oral HIV self-testing, provider-associated testing, and then nucleic acid or NAT testing. We found that the health impacts were similar by testing modality, but the number of people with undiagnosed HIV were slightly higher, or the number of people with undiagnosed HIV initiated on PrEP were slightly higher in the HIV self-testing scenarios compared to NAT and provider-administered RDT. But the resulting drug resistance was low across scenarios. And accounting for background resistance, the prevalence of PrEP-associated drug resistance was similarly low and lower than in the no PrEP scenario because of that reduction in HIV incidence. And specifically towards the budget impact. So in Kenya, the cost we assumed for HIV self-testing for both oral and blood are not substantially higher than provider-administered RDT. So we found that the budget impact was similar across those scenarios, but much higher for the NAT testing, and that was driven by the high cost of the test itself. So overall, we find that benefits of community-based PrEP distribution using HIV self-testing would outweigh the risks of drug resistance.
Okay, thank you so much, Dr. Manisha. Very interesting, and I think it would be really interesting to hear more about this, but very interesting to understand, people to understand that the overall benefits are community-based PrEP is beneficial using HIV self-testing. For the sake of time, I'll hand over to Michelle to see if our last panel is online or to close the panel. So thank you so much for listening to us.
She is. Katrina Ortblad is here, although her name says Monisha Sharma. So if you can put on, hi Katrina. Katrina's just put on her video. You can unmute, you should be able to unmute yourself. Perfect. Great, glad you could make it. And I know this is not a favorable time in Seattle, so extra appreciation for you. So I'm going to, Dr. Katrina Ortblad is an assistant professor of public health sciences at the Fred Hutchinson Cancer Center in Seattle. And Dr. Katrina is going to, I'm just going to ask you some questions about the systematic review and the GPREP trial that you're leading in Kenya. And I'd just like to ask if you could elaborate on the observed impact and effectiveness of HIV self-testing in PrEP delivery. Additionally, what key strategies or advice would you propose to enhance self-testing uptake within PrEP delivery programs based on your findings and expertise? Over to you, Katrina. Thanks for being here.
Yeah, no worries. Thank you so much. And apologies, I logged in via the link Monisha shared with me. So I am Katrina Ortblad, not Monisha Sharma. So we conducted a systematic literature review in collaboration with the WHO roughly 2 years ago. And when we did that review, at the time, we actually only identified 3 studies that had effectiveness data on the use of HIV self-testing for PrEP continuation. And we had, at that time, we actually didn't identify any studies that looked at HIV self-testing for PrEP initiation that had sort of a control group. And the studies that did use HIV self-testing for PrEP continuation used it in different ways. So one of them packaged HIV self-testing with biofeedback as well as adherence counseling. Other ones used HIV self-testing for testing between scheduled PrEP clinic visits to help people confirm their HIV negative status as sort of an incentive to continue using PrEP. And then the project that I worked on, that was one of the randomized controlled trials included in this literature review, which I conducted in collaboration with Dr. Kenneth Nguri's team at the Jomo Kenyatta University of Agriculture and Technology in Kenya, was an intervention that used HIV self-testing to support six-month PrEP dispensing to reduce the number of annual clinic visits in half. So it was an intervention that targeted PrEP continuation, but was intended to use HIV self-testing to simplify PrEP delivery by replacing a facility-based visit with HIV self-testing between clinic visits. to reduce the frequency of having individuals go to the healthcare facility. And in all these studies, we found that HIV self-testing did not have any detrimental impacts on PrEP continuation outcomes. So HIV self-testing, recent PrEP refills and PrEP adherence. The randomized control trial that we did in the procurement of PrEP study that I just discussed in detail was actually a non-inferiority trial. So we found that the intervention sort of worked as well as and it resulted in equivalent PrEP continuation outcomes compared to quarterly clinic visits. There's other projects our research team also recently completed a study that looked at an online model of PrEP delivery, which we got special permission from the Kenya Ministry of Health to use HIV self-testing to initiate clients on PrEP in an online delivery model, where clients would have a telehealth visit with a remote provider, then get an HIV self-test sent to their home. They'd conduct the HIV self-test, and then they upload it to an online platform where it gets confirmed by the telehealth provider before PEP and PrEP drugs are sent to them. And in that model, I think another interesting element there was we worked in collaboration with Autoré, which is a digital health technology company that used AI and computer vision to help interpret the HIV self-test results that were uploaded via this platform to be an informational to help clinical providers inform clinical decision making, but also to be a quality assurance tool for records if ministries of health were sort of interested in scaling up a model like this. Michelle, I think you're on mute.
It's a classic. I just wanted to ask if you could just speak about cost or cost effectiveness. And I know I didn't ask you this in advance, but it is really important to bring it up in this forum, because that is a cost that we all hear. In South Africa raised about the cost of the individual test kit, but there's the individual test kit cost and then the broader cost to incorporating self-testing in PrEP programs. And your thoughts would be really appreciated there. Thanks, Katrina.
Yeah, so when we did this systematic literature review, we actually there was no published literature on sort of costs in using HIV self-testing for PrEP continuation. But as part of this Premature PrEP trial, we did do a cost effectiveness analysis, and that manuscript is in submission at the moment. And we found that by utilizing HIV self-testing kits to replace clinic-based visits, it reduced cost of PrEP programs. So the idea is that a large percentage of costs associated with PrEP delivery are providers' time and effort that's spent on sort of associated counseling and testing services. So if you can reduce the number of facility visits in half and move the HIV self-testing to individuals' homes, that over the long term can reduce costs while maintaining equivalent health outcomes. This is sort of what our research is suggesting, but I think it would also be, this was done in one randomized control trial, and I think we're also hoping to get some funding to then do this at scale in public clinics and across a randomized control trial.
No, I mean, thank you for explaining that, because that is a major concern, especially in this, political and prevention climate as well, just to make sure that we can have sustainable programs. So, Katrina, thank you so much for being here. And thank you to all of the panelists for taking the time and sharing your energy and thoughts on this panel. This has been really excellent. I'm going to hand over to Kat for the Q&A session. I believe we still have, yes, I think we still have some time for that. So over to you, Kat.
Thank you, Michelle, and thank you to our panelists, and thank you to everyone who's been putting so many great questions in the Q&A. And I can see a lot of them have already been answered, which is great. I have a few I'd like to pull out now. We have about 10 minutes for Q&A. So first, Isatu Sar asked a lot of great questions about implementation science and HIV self-testing. And I thought maybe I could direct this to Carlotta, because I know you've been doing some mapping lately of implementation science and HIV self-testing. And Isatu has asked, how does IS contribute to ensuring equitable access to PrEP and HIV self-testing services, particularly among marginalized and vulnerable populations? And maybe you can speak a bit about some of the IS that's going on now that's looking at HIV self-testing.
Yeah, so we have been collecting some case examples from all over the globe, and it was quite interesting because we do have a lot of cases for continuation. So we do have many countries considering to use HIV self-test for continuation, and because of this, they save time and they don't have to come back to the consultations. But we do also have a lot of contexts using it for PrEP uptake and then going a step further on initiation. And this really is targeting the key pops and those vulnerable groups that don't want to sometimes take the initial step. And there's a lot of interesting models, including the use of virtual interventions. And so we heard about AI, but we do have the simple texting on the negative HIV self-test to the healthcare provider and then shipping up their bottle of PrEP together sometimes with STI self-sampling, such as some cases of Eswatini as well. Eswatini also presented a case of linking PrEP to PEP, to STIs, to index testing. So there's a lot to be done, but we do see that this has taken a lot of benefits, specifically reaching the most difficult to reach population.
That's great. Thank you so much, Carlotta. And now I have a couple of questions for Vusi. So Vusi, if you don't mind coming on camera and unmuting. First, we had a question asking if you distribute self-testing kits through social marketing. You could just a quick answer on that one.
Yes, thank you, Kath. Yes, we do distribute HIV self-test through social networking, and they are then being followed up, for results through our community PA outreach workers. Thank you.
Thank you so much. And then we have another question for you, Vusi. It says, from Grace, amazing progress in Eswatini. How are you managing monitoring for PrEP continuation? And did you have to revisit your PrEP indicator definitions and monitoring tools? And I just wanted to bring this up because there is also going to be another webinar in a few months on monitoring evaluation for PrEP. So I think it's good to get on people's minds. So Vusi, if you could just share a little bit how you're monitoring this.
Oh, okay. No, thank you. Thank you very much. So the first thing I can say is that we are only starting. We started a month or two ago implementing this, and the indicators have not changed. PrEP-CT is still a quarterly reported indicator, still looks at refills and reinitiation within the reporting period. And, we are alive to the fact that multiple months dispensing with HIV self-test kit will compromise continuity at that quarter, but we are also considering the semi-annual, great progress that we'll harvest. But nonetheless, our clients are also followed up, just to check if they took their medication, and we are still in discussions in terms of self-reported remote PrEP consumption versus facility when the client is in front of you and saying, I was taking PrEP. So those are some of the discussions and considerations we are currently having as a country.
Thank you so much, Vusi. I really appreciate you sharing your experiences. Great. Now I have a question. I think this would be one for Cheryl. Is there a country or context where non-clinicians are authorized to prescribe PrEP? Or we could also open up to any of our country representatives if they are able to share.
I think this is a question. I know there's been active work in South Africa to enable non-clinicians to prescribe PrEP, but I'm not 100% sure. If maybe Michelle or Hasina actually might be better placed to speak about the South Africa kind of program.
No, exactly. Let's have it. Hasina's raised her hand. She is best placed to answer about South Africa and also can speak about nurses as well. Over to Hasina.
Yeah.
Great, thank you, Hasina.
So in South Africa, the majority of PrEP is prescribed by nurses who are authorized to prescribe based on their training and the necessary authorization depending on where they work. We do not have any lay health worker like community health workers or counselors or peer educators or health promoters that can initiate somebody and prescribe oral PrEP or any medication for that matter. There is some legislation that has recently been passed to allow pharmacists to prescribe a medication, but the actual process for authorizing pharmacists to do that hasn't been finalized yet. So at this stage, it is our medical officers and nurses, professional nurses that are currently authorized to prescribe and dispense medication. Thank you.
Thank you so much for sharing, Hasina. That's great. And we hope all this, everything gets passed soon. I have another question now. Maybe I'll just leave this open if anyone from a country or Cheryl would like to respond. Does anyone have any experience using HIV self-testing for initial 3-month dispensing of PrEP? Any of our country programs want to weigh in, or Cheryl?
I think as WHO, I don't have direct experience with implementing 3-month dispensing. But I wonder, from the research context, Katrina could speak a little bit maybe from her work on implementation, which I think it's a little bit different, but maybe is still relevant. Katrina, maybe you can just adapt to say, based on your experience, how that might be applicable here.
Can you hear me? Yeah. We've used it to HIV self-testing to replace a clinic visit. So individuals receive 3 or 6 PrEP bottles for a 6-month supply, and then they're instructed that after they complete their 3rd bottle, so after 3 months, they test themselves for HIV using the HIV self-test. And if they're negative, then they can carry on the next 3-month supply. So that's sort of how we've used HIV self-testing to help with 3-month dispensing in lieu of a in-person clinic visit. Does that help answer the question?
Yes, thank you so much. That's great. Okay, I'm just having a look through some of our other unanswered questions here. Some are country specific, and I'm not sure we have anyone from those countries here. Although if, excuse me, if anyone here, any of our participants, doesn't have to be a panelist, who's from representing Brazil or Namibia, if they are able to speak on those, then please do raise your hand and I can call on you. We also have a question here. How can we provide UNHCR to provide asylum-seeking refugees PrEP self-tests at no cost? Does anyone here have any experience providing self-test kits to asylum-seeking refugees? Can we respond to the question?
Pat, I don't have experience, but I am going to just put out there that I know that our colleagues in PAHO, so Latin America and the Caribbean, are doing extensive work on providing HIV prevention services to migrants. So in our discussions with different colleagues, we are looking at incorporating PrEP services and HIV self-testing in that. But that's really something that's specific to that region. Over.
Thank you so much, Michelle. No, that's really helpful. That's something we can also look into in a bit more depth later. Now, we just have about 5 minutes left. So I think I'm going to hand over to Cheryl to wrap us up. But if you have any more questions for our panelists or about anything today, please, you can always write to any of us directly. I'll put my email in the chat. You can just write to me directly and I'll direct your query accordingly. And of course, again, we'll be posting the slides and the recording and everything and sending that out. So you'll have access to that as well. Thanks. So I'm going to hand back to Cheryl.
Thanks so much. I just want to thank all our wonderful panelists in the countries for really sharing their experience. We're still in the early days, I think, of self-testing for PrEP. So I think it's normal to have a lot of questions. We don't always have the answers, but it's great that we're getting started to figure things out. And I want to thank Monisha and Katrina for joining us as well, really sharing from their kind of academic work, some of the implementation science they're also involved in, which is really relevant right now as we think about adapting what we've learned so far for the real world. A few reflections I really took away from this call is that one, countries are doing a lot of different things. Even just hearing today, things are changing, policies are starting to be developed. We're in a kind of a space where I think it's really exciting to think what's going to happen. So I'm definitely taking away from this that it's important we have continued follow-up to hear more country experiences. And I do want to make a shameless plug that there will be a think tank on self-testing and PrEP that AVAC is organizing. And so Kat can share more about that and how we can leverage, more webinars and more dissemination of the early lessons learned through these different platforms. I think one other thing that really stood out was teleprep, virtual intervention, some of the tools that seems to go hand in hand with a lot of the self-testing and PrEP implementation, whether it's for the monitoring piece or the linkage, the communication. And so I think that's a really important thing that we're seeing a lot of countries and programs take forward. So if that is something we need to really be advocating or learning more about what's the best way to use virtual tools, I think that's a really good one to learn from and start expanding on. I think we heard some different concerns about the issues. We heard from countries about, what if we miss cases? What if we have higher costs, the unit cost per test versus a professional test? What are the trade-offs? And so it was a really nice discussion, I think, with thinking about ultimately self-testing for PrEP could be cost effective. There's one experience out of Kenya that was shared with us on this call that did find cost effectiveness due to reducing health worker time and facility visits. And we're not even factoring in the benefits of increased access, how we're averting new infections by getting more people on PrEP. More people being able to effectively use PrEP is going to be extremely beneficial to our goals. And so I think that that's a really important reflection that when we think about costs, we may need to be moving outside of just what's the unit cost of this self-test to what is this cost of this program and how do we really achieve our goals effectively. And if self-testing can get us there and is affordable, it may be the right way to go. I think for many, many years, we've seen PrEP programs struggle to get enough people on PrEP and to be effectively using it. And I really would say we now have some guidance available to offer a new option and a new pathway to new clients and new users. And so I think we've really learned we just can't continue business as usual. We have to kind of be going outside the box and thinking about making client-centered services for people who need to access PrEP but might not be coming in because of the barriers. So low barrier services that self-testing can enable is really that's what the WHO guidance is advocating for. That is where simplified PrEP delivery is going. And really it be encouraging that as a top line message from this webinar. And then lastly, I think on some of the risks and benefits, I think we have to continue to think about self-testing is not a magic bullet. It's not going to solve all the problems. There's a lot of things we need to be thinking about overall and continue to improve those. And M&E was definitely one that was coming up. I'm glad there's going to be more discussions on PrEP M&E and how we can be optimizing PrEP programs. Thinking about the future. And so I just felt like we've covered so much ground. There's a lot to do. I think our work is cut out for us. We hope to see, I think, a lot more expansion of self-testing for PrEP delivery and learning more. And I'm excited to hear back from these countries, maybe in a year's time, to see what's changed and how things are going. I think we'll continue to really make advances. And I just want to thank everyone for the excellent questions, the fantastic inputs, and really appreciate the AVAC team for coordinating this webinar and really getting this great audience of countries, implementers, activists, and community groups together to really talk about this and think how we can move forward. So thank you, and back to you, Kat.
Thank you so much, Cheryl. Great. So it just leaves me to thank everyone. Thank you so much to our speakers, to our panelists, to everyone who's joined today. Please look out for those links to the recording, to some notes, to the slides, and look out for an invite soon to a really exciting webinar we're hosting with the choice agenda on M&E for PrEP choice, which will be in early August, and we can look into some of those details, some of those issues more in detail. Thank you, everyone.